Oh, that's cool. That's no, look, I mean, I think that's really good. So the other thing is the superior border, just in terms of um, the way I approach the anatomical description is really superior, anterior, posterior, and inferior, really. But and so sort of superiorly, I think you kind of mentioned it, but you're looking at zygomatic arch, and then inferiorly kind of mandible, anterior and posterior. You did well, and you talked about the superficial and deep portion of the gland, and you talked about the facial nerve, splitting the gland into its superficial and deep portions, and then running through the gland itself. I think running through the deep portion of the gland itself are those things that you talked about: the retromandibular vein, the external carotid. But usually they're not seen in the operations that we tend to do because they tend to be deep to the facial nerve, which is where we would stop your superficial parotidectomy, which I think is probably the main thing that we need to know about. Okay, so the next gland to talk about, let's see who else is here. Nobody else got their camera on, so Fiona. Submandibular gland location.
So the submandibular gland sits in the submandibular fossa, which is also the submandibular triangle of the neck when you're dividing that up. So it's bordered by the mandible and the two bellies of the digastric muscle. And the submandibular gland wraps around the mylohyoid muscle and has relations to the cranial nerve 12, the hypoglossal nerve, and also the lingual nerve, which is a branch of the trigeminal nerve. There's also the facial artery and vein that run just behind the gland as well, that are also encountered during dissection.
Very good. Yeah, and I guess the thing with the anatomy was that all of this becomes a bit more relevant when we start talking about how you would perform the operation, and we'll get to that in a minute. I think you got all the points for that. Sorry, just thinking. Except the only other thing was to talk. Sometimes they ask you about how the duct itself wraps around the lingual nerve, so it just goes over, under and across. Is the other thing.
Oh yeah, and where the duct, probably where the duct exits.
Enters.
Well.
Yep.
Yeah, so it exits on either side of the frenulum and the floor of the mouth.
Good, very good. Cool. And then I was actually planning to talk. Sorry.
Oh, sorry. I missed a little bit of that because I was on a call. But the facial artery and you're talking about the submandibular gland and the facial artery and vein, right, Fiona?
Mm-hmm. Yeah.
Yeah, cool. So the artery basically wraps under the mandible and then runs through the gland substance, and the facial vein tends to run over the gland. That's important anatomically. I mean, if it's if it's benign disease, we generally ligate them. But if we're doing a head and neck resection, the facial artery and vein are very important potential vessels for the free flap to be plugged into. So we try our best to preserve them. And the marginal mandibular branch of the facial nerve, sorry, I don't know if you said this or not, runs over the facial artery and vein. So if you want to try and preserve it and you're not sure where it is, you can ligate those vessels and retract them up, and that will pull the marginal mandibular branch up and away from over the gland.
Yep. That was coming.
Apologies.
That's all right. So I was actually going to talk about the anatomy of the gland separately, but you guys have actually described the relations and the anatomy together, which is great. can you talk me through how you would set up to perform, let's say, a superficial parotidectomy? Who has next? Cash.
Yeah, so patients positioned supine will place a roll under there, sort of around just behind the shoulder blades to further extend the neck. Antibiotic cover, whose surgical timeout, and there's obviously neuromonitoring set up in this image, so that would be facilitated partly by the anaesthetists placing wiring on the endotracheal tube, but also placing electrodes in the subcutaneous tissue of the chest. Yeah, it's the main.
Okay. So going back to the nerve monitor, with these ones on the face, you don't actually need the ETT because the circuit is basically to the muscles themselves. And the probes that you're putting in are basically detecting muscular contraction or twitching, basically. But basically the wand itself works very similar to how it works in a thyroid operation, where you get the grounding, one grounding lead, and then the one to kind of complete the circuit. And the only other thing is that you probably want to tilt the head to the other side, so the contralateral side. Sorry, I'm not sure if you mentioned that. And then some people would, despite the fact that they've got the monitors, some people would also prep and drape just the way that this picture is, where they would still have all of these visible, so they can see the contraction of the muscle itself.
Yeah.
But yeah, apart from that, yeah, pretty good. Usually the other thing to talk about is that I've in all the operations I've seen that this is done, they always have the arms tucked on both sides, really for access, so you can get to above and below, and all your assistants can get around the table. Yeah. So, Sharon,
sorry, one sec. Who here, can you guys put your hands up, like who's actually seen a parotid operation? If you do a little vote. I can't see everyone, sorry. Because everyone's camera's off. Cisco's seen one.
Yeah, I've seen one. I've seen one.
I've seen it on YouTube, but I think I can do it. If you guys do before the exam, it's probably one of those things, if you get the chance to sidle into a ENT list or somewhere where there's happening, and that doesn't happen every day, but just if you see it, then it just makes you much more kind of stick, and then when you go to describe it, it sounds like you've actually been there rather than just read it in a book, because as soon as you see them set up, you go, oh yeah, I got that. So it's definitely worth it, and just ask them how they set up the monitor, because it's something that you need to know how to run.
It was a question last week in the written.
Oh, was it? Thank you, Sharon, for making this such a live and realistic shoot. Yeah. All right, excellent.
What exactly did they ask about the NIM out of interest?
So it was a picture of a thyroid setup, and the question was something to the effect, I've blocked it out already, was, what is this monitoring device and why is it used, type thing, and then how does it work, and what is the importance of having the endotracheal tube placed in the right position. And then the last part was, you're doing I think it was a Graves or something, and you lose signal for the nerve after doing half of the operation. What do you do?
Yeah.
That was a whole short.
Yeah, wow, yeah. What I would say about the NIM, and Ian pointed it out, is I would prep with like an IOBAN across the half face so you can see the face. A couple of reasons for that. If the NIM goes down, you can still see face twitching. So you can't rely, like a thyroid. If the NIM's playing up, you can't rely on it. You just have to rely on what you're finding clinically and your anatomy. It's a useful adjunct, but it's not it's not a pair of water wings. The other thing is, generally, depending a little bit on the institution, you might only monitor 2 of the facial nerve branches, generally orbicularis oculi, because the 2 most important functions of the facial nerve are eye closure and lifting up the oral commissure. So you do orbicularis oculi, and mentalis, but you may not check the buccal branch, and you may not check the temporal branch, although you can set up a 4-channel. So if you've only got 2-channel monitoring on, but you're working around another channel, it may not necessarily ping on the monitor. It probably will, but you will see the face twitch. Yeah, and you're right, you ground, just like the lymphothyroid, ground electrodes in the chest, and then you have a monopolar stimulator to check the nerve branches. The name of the incision is the modified Blair incision, so you could...
Oh, hang on.
Yeah. Oh, sorry, apologies. Okay, I'll stop there.
So I was going to ask Sharon to describe your surgical approach to a superficial parotidectomy.
So I guess the most important thing with your approach to a superficial parotidectomy, the main aim of the surgery is for identification, preservation, and dissection around the facial nerve, and then removal of the tumor in the superficial parotid tissue. So the way you do that, so what you've got there is the picture of the modified Blair, and that's favoured because you can extend that incision later if you have to do further neck surgery. So that's it used to be just a straight incision. So my approach would be with the facial, and Cisco will have to correct me, it's the SAMS or the S smash or something, muscle nerves of the
SMAS, superficial muscular aponeurotic system. Yeah.
So I think you do it, is it a subplatysmal flap to try and preserve that, and then your anatomical markings, I use a anterograde approach to the facial nerve identification, in which case I would find the tragal pointer, which is that the inferior-most part of that cartilaginous point, go along and down to, I think it's to is it to digastric, and that's your most inferior aspect of your dissection. And then once you get onto the capsule of the thyroid itself and identify the nerve, you can use blunt dissection to elevate the parotid tissue from the facial nerve. Yeah, that's about all I have to say about that. Yeah.
Okay, so if
comment? Go ahead.
Sorry, apart from the tragal pointer, what other potential landmarks could you use?
Okay, so there's an inferior extent of your dissection as well, which I can't remember what it is, but if you can't find it with your tragal pointer, you can find the distal branches and do a retrograde dissection as well.
Yeah. So they talk about tympanomastoid suture as well as the as it comes out of the stylomastoid foramen. So that's kind of posterior and slightly inferior to the end of the tympanomastoid suture. Tragal pointer, the retrograde dissection, and in some cases you can also actually go through the mastoid bone, depending on if you think you need to perform a mastoidectomy at the same time, and that allows you to track the facial nerve from its origin, once again in the stylomastoid foramen. And sorry, the other thing was, the last thing you mentioned was actually the posterior belly of digastric, so it lies just behind it, I think. Yeah. Sorry, Cisco, you had a comment before.
Yeah, that was pretty good. I would, like you mentioned, there's basically 2 ways to do a parotidectomy: retrograde and antegrade. Antegrade is the traditional method, what most people would do. So for your purposes, antegrade. in the exam, you don't want to be seen as a little outside the box, but knowing a little bit about retrograde is important. So yeah, modified Blair incision, sub-SMAS and sub-platysmal flap dissection, because the platysma only comes up to here. Above that, it's a sub-SMAS dissection over the parotid fascia. And your incision extends from just above the tragus, coming down around the earlobe, and then a lazy S down into the neck, 2 finger breadths below the angle of the mandible, because the marginal mandibular branch is at the angle of the mandible. So if you bring your incision 2 finger breadths below, you won't hit it. Then dissecting in a wide plane to identify the main trunk of the facial nerve along the tragal cartilage. So you're pushing the parotid gland and you're dissecting it off the tragal cartilage, and you follow that down, and that is like a corner that you come to. Inferiorly, yet you identify the sternocleidomastoid, and just anterior to that, you'll find the posterior belly of digastric. Facial nerve is always deep to the posterior belly of digastric, so if you're on the posterior belly, you know you're safe. You are right with the tragal pointer. That's a commonly used landmark. It's a little inconsistent, but the facial nerve is 1 centimeter anterior, inferior, and deep to that pointer. It is at 8 millimeters from the from the tympanomastoid suture, which is the suture of those 2 bones, and you can palpate that quite easily intraoperatively. If you carry your dissection on down between the parotid and the tragal pointer, you may hit the styloid process. If you get to the styloid process, you're too deep because the nerve is lateral to that. But if you're on the styloid, you can go up and down it carefully until you find the facial nerve. Okay, I'm just doing a little chat. Okay. Go get dressed. Okay. Sorry about that. Yes, and then a mastoidectomy to find the facial nerve in the mastoid bone. That's the last resort, really, but you can do that.
Yep. Yeah. So essentially, as you correctly identified, this is kind of a picture of a modified Blair, and then that back cut, as you say, is sometimes used to. If you need to do something like a neck dissection together with the parotidectomy, and so that will give you a flap, which then allows you to lift everything out and then allow you access to the neck. Okay. Yeah, I was kind of trying to show you the anatomy of the facial nerve once the parotid gland has been taken away, but actually I don't think the picture is actually projected as well as I thought it did. So let's just get past that. Complications of parotidectomy, Tara. Sorry, you're muted.
Sorry. So the general complications would be bleeding or hematoma and infection. The other ones that are more specific to parotidectomy would be obviously facial nerve paralysis or temporary weakness. You can get Fraze syndrome, which is gustatory sweating and flushing. Can have a salivary fistula, and yeah, I think that's the main thing.
Sorry, I'm mute now. But essentially, I remember it kind of with the Fs, the fistula, the flap, the fistula, Fraze, formication, and flap necrosis was the other one. Because as we talked about, usually it involves a flap, and if the flap is too thin, it can necrose. And sorry, facial nerve problems. Now, can you explain the mechanism by which Fraze syndrome or formication occurs, or Fraze syndrome occurs?
I know it's something to do with the division of the parasympathetic nerve fibers that then regenerate in an aberrant fashion.
Mm-hmm. So neuroplasticity does contribute. The other thing that's interesting is in this area, the neurotransmitters for both the sympathetic and parasympathetic system is acetylcholine. And so if the flap is too thin or thin enough, the parasympathetic nerve fibers can then regenerate towards the sympathetic and nerve endings of the sweat glands, and then when you eat something, you get gustatory sweating, which is Frey's syndrome. Do you know how you might be able to test for it? Yep, Sharon.
It's usually a late complication, so it's usually at least about a year post-op, and you can test for it using the modified starch, or iodine starch test. So I think you put iodine on and then starch, and then give someone something to eat, and then the sweat comes through. The management would be either usually medical, so you can use like topical deodorants, and also I think Botox as well can be used.
Yeah, Botox is the other option to basically just paralyze the nerves. So you're right, it just changes the color of the starch, the starch, iodine and starch. Cool. And that just the other thing is that the usefulness of that is that it actually gives you an area to concentrate the Botox into, rather than just targeting the entire flap.
What is the risk? This is for anyone. What is the risk of facial nerve palsy with
Recording in progress.
I would I'd mark just like that. So I'd mark an incision, I think it's 3 finger breadths below the angle of the mandible, extending from just past the midline to the medial border of the sternomastoid muscle. Then I would raise flaps. I would first look out for the marginal mandibular branch of the facial nerve, which will be running superficially. And then I would follow my dissection to the mandible, and then identify the submandibular gland, and the structures we talked about, the facial artery and vein curving around it, and the hypoglossal and lingual nerves running through it, or between mylohyoid and the other muscle. Mylohyoid.
Any advances? Anyone else? Okay, so my understanding was that so you probably don't actually want to raise a flap immediately. You make that incision about 4 centimeters below the angle of the jaw, because that's how low the marginal mandibular nerve can go. And then you perform your dissection all the way down to the capsule of the submandibular gland itself. And then following that, usually what we could do is then identify the posterior part of the posterior part of the facial vein, posterior part of submandibular gland where the facial vein tends to run, and then you ligate that using that as a retractor, sort of as a retraction device. You pull it upwards and then raise your flap underneath it. And that that will lift that marginal mandibular gland away, as we talked about earlier. Sorry, marginal mandibular nerve away, as we talked about earlier. Following that, you have the option of then dissecting. So you then dissect the gland from posterior to anterior, and then you have the option of either dividing the facial artery inferior and superior to the gland, or you can divide all the little branches that divide the gland in two, and that's your posterior to anterior dissection. Following that, and then after that, you want to go anteriorly, dissect it away from mylohyoid muscle, where you then lift your mylohyoid muscle anteriorly and outwards and anteriorly, and that kind of divides the deep, superficial and deep portions of the gland, and then you know that your nerves are going to run deep to mylohyoid. And as long as you're lifting that away, you can then visualize the nerves itself, and then perform your dissection from anterior to posterior dissection. So then you meet up, and then you look for your duct and ligate that as high as possible. So yeah, as you say, the main structures you're really looking for are your lingual nerve, your hypoglossal nerve, and then superiorly your marginal mandibular nerve, which is the main thing that you really worry about, especially when you're approaching it. And often you will encounter the submandibular ganglion, and just a little aside, the contribution from the submandibular ganglion does come from lingual nerve, so you may have to divide bits of that as well, as it contributes to the superficial part of the gland.
You always have to divide the submandibular ganglion because it is connected to the gland. It connects the lingual nerve to the gland. So yeah, those answers are correct. Incision 2 finger breadths below the angle of the mandible. There's various different the marginal mandibular branch is immediately deep to that. And like we mentioned, it will be running over the facial artery and vein at the lower border of the mandible. That's a great place to find it. You can actually see it. I prefer to then dissect it free and elevate it up, but you can do the Hayes-Martin maneuver, ligating the vessels and pulling those up without specifically dissecting the nerve. In either approach, you're now looking straight at the submandibular gland with the vessels and the nerve up and away from it. I like to find the posterior belly of digastric and dissect along it in a V, posterior to anterior. So then you freed the gland off the digastric posterior and anteriorly. Then I like to retract at the front edge of the gland, retract that back. That will show you mylohyoid, which it's lying on. And you retract mylohyoid forwards, dissecting away gently with the monopolar. At that point, you'll start to see the lingual and the hypoglossal nerves, which are deep to the gland. The hypoglossal nerve is inferior and the lingual nerve is superior. The lingual nerve is a characteristic bowing with the submandibular ganglion at the sort of apex of the bow, and that's where it attaches to the gland. You have to ligate that. You also have to free it from its attachments to the mandible superiorly, and then clip the submandibular duct at the end, because otherwise you can get either saliva refluxing into the wound and then an infection.
Cool. Thank you. So yeah, so this was kind of a picture. What I'll do is I actually send out a link to this video that I watched before I did the exam, which I thought was quite useful. But yeah, I think the technique they described was what I ended up describing, so slightly different to, yeah. And then, so the main complication would be, so the other complication, what complication is this illustrating? Who's after Fiona? Prakash.
The facial nerve, or branch of the facial nerve palsy. Is it? I'm not sure. Is it marginal mandibular or?
So it is marginal mandibular, but so what weakness is this?
The weakness of orbicularis oculi? No, sorry, orbicularis oris.
Yeah, it's just, I think it's just a depressor of the lip essentially, isn't it? Yeah, cool. And I think in terms of treatment of these complications, maybe you can help us out with this, Cisco, because I found it quite difficult to figure out what we would usually do. Some people talk about Botox off the other side to symmetrize, but yeah.
Yeah, so marginal mandibular, the value of the marginal mandibular nerve, I think, is somewhat overstated. So it basically does depressor anguli oris. So on the photo you got there, the weakness is actually on the patient's right side because she's unable to lower the lip. So often if people have a marginal mandibular weakness, they're not even aware, and it's only when you talk to them in clinic and point it out to them. But for some people, because it does change their smile, can be quite upsetting. Yep, so Botoxing the contralateral side to give them some more symmetry is a consideration. You can consider other techniques such as, well, not specifically for the marginal mandibular branch in itself. Generally, we do nothing at all. But in the setting of a more, like, having to divide the nerve for malignancy, you might do a dynamic reanimation, so nerve transfer. There's several different options for that, but you could do a dynamic reanimation with nerve transfer. Or if you're dividing more of the facial nerve branches, you can also do static facial nerve reanimation. Once again, not specifically for the marginal mandibular branch, but for the other branches. So that's what I would talk about. Other complications are just your standards, infection, collection, in the setting of malignancy, tumor spillage. Just as an aside, the submandibular gland does not have lymph nodes within it, unlike the parotid gland, but it's got 3 or 4 lymph nodes in close association with it. So we routinely remove it as part of our neck dissections for cancer.
Great, thank you. Cool, and this is the last slide, and I just kind of found this diagram useful to remind myself with regards to head and neck where things are and what kind of levels disease. It's not exhaustive. I left it in because I found it useful to refer to as a guide. So I don't have any more slides. If you guys have any questions or anything like that, please feel free to ask away.
So neck dissection.
Recording in
and all the way
progress.
back down here, because we've mobilized a huge flap of skin, which we're then going to rotate up over the defect. We've taken the skin over the parotid because it was obviously involved. Most of the parotid's gone here. This is taking out the masseter, which is underlying the parotid gland, and the tumor was invading masseter as well. So here you can see the sternocleidomastoid, external jugular turning into the retromandibular vein, and here you see the facial nerve. So here's the main trunk. You can't quite see the tragal pointer, but it's roughly there. Main trunk. This is the superior divisions here. So this is probably the temporal branch. Actually, no, the temporal branch is here. This is a zygomatic branch going up to the eye, so eye closure, very important branch. This is the main buccal branch, which we preserved. Going up to depressor anguli oris. Facial vein, you can see the marginal mandibular branch running over the vein there. And then this is a cervical branch going down to platysma, which we cut. It's not an important branch. Yeah, and then down here, sternocleidomastoid. That was the omohyoid coming there, which we preserved. And we've removed the lymph nodes from levels 2, 3, 4, which are under the sternocleidomastoid there, as well as level, oh no, we didn't do 1B. Sorry, we left 1B. We left the submandibular gland there. And then so once we'd done that, swung all this skin back up. He'd initially been consented for dynamic reanimation of the facial nerve because we thought we'd have to take the whole thing, but because we've preserved most of it and we've only taken one branch that just does a little bit of upper lip raising, he's had no reanimation, and he's actually going to have a really nice result. So he's going to do quite well, I think.
That's fantastic.
It's gorgeous, Isco.
Thanks. Yeah, I was pretty happy with that. It was a fun case.
Well, really radical, like that kind of thing. How do you decide when you're gonna have to take skin? Is it when is it you can see it macroscopically, or is that a scan? Or is that
Yeah, so this one was quite obvious because he just had a massive ulcer right over his parotid gland, and his facial nerve didn't work that well. So we're like, okay, it's kind of obvious what we need to do here.
From the country?
Yeah. He was from a small town, sort of, neglected skin cancers. You'll see lots of those as well, especially if you guys work rural. You'll see heaps of those. Yeah.
Just can you just comment, because this is one of those things that having you as an expert is really useful for working up a parotid lesion.
Mm-hmm.
Where do you see the role of FNA? Is it useful or not useful, or is it mainly radiology?
Yep. No. So FNA is very useful. Like I said before, it's less accurate. That's the important thing to remember. But what it can help you do is triage and help with your decision making. So if you get someone who's got a very benign looking small mass, no nerve or skin involvement, no history of malignancy, no red flags, you do an FNA, it comes back as a benign tumor. You can reassure them and say, look, nothing about this looks malignant. There's still a chance that it is malignancy, but we don't need to do this operation next week. If they're comorbid, you may decide to just watch them and see what develops, etc., etc. Conversely, if you get an FNA that shows malignancy, then you just have to crack on and get treatment instigated, even in the, and just accept that, hey, actually, we might be over-treating you, but this is the information we have. So an FNA is very useful in that respect. And especially in like an older patient who's unsure about surgery, if you get a reassuring FNA, then you can be happier about just watching them.
Any other questions, guys? Because it's a nice opportunity with Cisco here to ask him all those things before we get asked in the exam, and then you feel silly because you didn't know to ask them.
I had a question. When they're talking about, like, so if you were, I don't know, would we be presented with a situation where we're working up a parotid tumor and they ask you sort of what operation would you do, is it always a superficial parotidectomy? Like when would you do a deep, when would you take out the deep lobe as well? Would that be like would that be an intraoperative decision if you noticed that it was going, or does that superficial deep distinction not actually matter that much in practice?
Yes. So that's a really good question. Like a lot of surgeries, the terminology is kind of vague and not uniformly applied. The vast majority of parotidectomies are what we call superficial, so taking the tissue, some, not always all, usually not all, but some of the tissue lateral to the facial nerve. Generally, you identify the tumor, dissect out the nerve branches until you've freed them from the tumor, and then just take out the tumor with a cuff of parotid and leave the rest of the tissue. So if you want to be technical, that's partial parotidectomy. The deep lobe is a really challenging area to operate on, so we generally do not unless we have radiologic evidence that there's disease there. So for a deep lobe parotidectomy, not always, but you often have to do what we call a mandibulotomy, so a vertical incision through the ramus of the mandible, just to allow you to slide the mandible forward and get you better access behind the mandible into the deep lobe. The facial nerve is at far higher risk, as are the other lower cranial nerves that are in that area. And if you get bleeding in there, it's also very difficult to deal with. So yeah, that it's basically dependent on the imaging and the pathology. If that answers your question. It's not something we routinely do. We do it fairly rarely.
Yeah.
And more would you say, I don't know if you covered it and I zoned out. Did you talk about drains at all? Like, do you use drains for a parotid or something different?
Yep. So once again, in the exam, conservative answer, I would put a drain in because you can't really get challenged for putting a drain in, but you can for the converse. Not everyone does a drain. I would generally put one in, essentially because I don't think the morbidity of having a drain in is very high. And you do have a decent chance of having a sialocele or post-operative collection. So, yeah.
Just on that, you don't tend to drain the sialoceles, do you? You just kind of leave them, they're just going to get better on their own, eh?
Yeah, we try and resist, aspirating or draining them unless they're causing significant issues. Because then if you stick a needle into the sialocele, you run the risk of just converting it into a salivary fistula. And that's way more difficult to deal with. So a sialocele, it will swell up. It can be quite tender and tense, especially when they chew. Generally Botox to the gland. You can do things like hyoscine patches as well to decrease saliva production. Small risk of serious side effects of hyoscine patches. I've seen a patient become frankly psychotic with hyoscine patches, so that's rare. But yeah, you can aspirate them. You just have to be careful of that salivary fistula risk.
That's fantastic. Thank you. Anyone else got any other questions? And we do, of course, have a comprehensive summary that's coming out that Helen's going to send to everyone.
Yeah, and I can send you guys my notes as well. And the other thing, I mentioned retrograde before, but we didn't really talk about it. So if you're struggling to find the main trunk, and generally you need loops to do this, but if you've got loops, you can find the marginal mandibular branch, like we've talked about, at the angle of the mandible. So you can actually dissect gently, palpate the angle of the mandible, and then just look around that area carefully. You find the marge, and then you can just trace the marginal back carefully and find the main trunk that way. And you do that. I'm sure you guys use similar techniques in gen surg, but something like a mixture or McCabe, fine artery forceps, just over the nerve, spread, make a little tunnel, lift them up, divide the tissue between your tips with the nerve deep to you and on show. Then again, over the nerve, spread, lift up, divide the tissue between the tips carefully. Who's sitting exams soon, by the way?
If you can guess who's sitting the exam, who's answering with big confidence.
Yeah. Is it the Vivas for you guys in a couple of weeks? Is it?
Yep, it'll be 4 weeks on Friday.
Oh yeah. Exciting times. Exciting times.
You're the only one, aren't you, Sharon? Like only one on tonight that's sitting.
Yeah, I think so. I don't know who's actually here listening.
It's good practice.
Yeah, looks like.
Yeah, it's kind of mean you guys get quizzed about this when most of you don't see it in training, eh?
It's just not worth being upset about what's mean about our exam that we don't see, but make your peace. I just think we get all these guys from other services and we can never pay it back. It's not like, hey, if you ever need to describe a hernia, we could run a session, but you never do.
Yeah.
Actually examined on what you do, but that's general. We love it.
Yeah, tell me about hyacinths. I love hyacinths.
I can do that.
Yeah.
All right. Hey, thank you so much, guys. Hey, Ian, wonderful.
Thanks, Ian.
Thank you very much. Thank you, Cisco. That was really
helpful.
Thanks, guys.
Thanks so much.
Thank you, Jay.
Amazing.
Thank you.
No, that's all good. I'm happy to be contacted if anyone's got any questions, and I'll send out my notes.
Great. Oh,
Thanks, Cisco.
Cool.
Bye.
All right, bye.